So welcome everyone to our webinar, Perspectives of People Who Use Methamphetamine on Reducing or Stopping Their Use. To go over just a few Zoom logistics again, participants can't share their video or audio, so enter questions into the Q&A or the chat and we'll try and monitor it. And if it's going to come up anyway, we'll just hold off on it. But if it is timely, we'll answer it. And we'll also have 15 minutes at the end for questions. The webinar will be recorded and posted here on our ADAI webpage and also here on Stop Overdose. So we'll just start by introducing ourselves. Sierra, do you want to go first?
Yeah, sure. Hi, everyone. My name is Sierra. I am a second-year Master's of Public Health student, and I actually got to help with these interviews that we're going to talk about as part of my MPH practicum. So it's just been a really rewarding experience and a project that I got to be a part of. I'm really grateful to Allison and everyone else at ADAI, and especially all of the people who are willing to sit down and talk with us and share their experiences and thoughts with us. Yeah, I'm really excited to share what we've learned from these interviews with you all.
Sierra's being a little modest in that she helped with the interviews. She conducted the majority of the interviews and was really involved in the analysis and in the planning. And so I'm just so thankful that she, worked with us. And I'm really excited to be able to share the results with everyone today. I think for me, this was a really valuable and rewarding experience, and hopefully this is useful for all of you. So I'm Allison Newman. I'm a continuing education specialist here at ADAI. I work on the website stopoverdose.org and learnaboutTreatment.org, and I do trainings and education on opioids and overdose, and a little bit of research with our syringe services programs here in Washington. So our agenda today, we're getting into the background introduction. I'll talk a little about methods and demographics. Sierra is really going to dig into the themes of what we learned. We're going to provide a few recommendations and then open it up for questions at the end. So I do want to start off by acknowledging that as we gather today, we are on the ancestral homelands of the Indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our Indigenous neighbors. And I want to add for our Indigenous colleagues, friends, and we have some Indigenous respondents to these interviews as well. So thank you. Usually thank yous are left for the end, but really want to put it out front up here because I think it's so important. Thank you so much to everyone who participated in this project, especially interview participants who shared so much about their lives and experiences. Thanks to our partners in this, Blue Mountain Heart to Heart and Spokane Regional Health District. You really made this possible in a challenging time because of COVID. And thank you to my ADA colleagues who worked with them on this, and that funding for this came from the Washington Healthcare Authority Division of Behavioral Health and Recovery. So just putting that thank you up there up front, because especially given that this was a little bit of a challenge to figure out during COVID, super appreciate all of you. So diving a little bit into the background, I'm just going to talk about why we did this and how we did this. So first off, we're not going to be able to get into every single piece of the report. So wanted to point you to it. It's on ADA's webpage. We have a full 12-page report, a one-page summary for syringe services program clients who may want to know the kind of things that we learned. We have an interactive Prezi, which is an online presentation where you can dive into the themes. Sierra will be presenting some of that Prezi as part of this. And so coming soon, a link to this webinar recording will also be on this page. So what's the background? Why did we decide to do interviews with people who use methamphetamine? A big reason is that methamphetamine involved deaths are really rising pretty dramatically in Washington. They've increased 600% in the last decade and don't really show any signs of slowing down. So it's imperative that we find out what could help people stay healthy. What do they want? How do we support people who are using methamphetamine to really improve their quality of life and reduce their chance of dying? And this is on ADAI's WA data page. We have a lot of information there about overdose deaths. It's a great resource that we try and keep as up to date as possible. So the other reason that we did this, it's really a complement to the biannual syringe services program surveys that we do. In 2019, we and our partners at exchanges conducted surveys with 1,269 people. We wanted to know, the purpose of this survey is to find out more about the health of people at syringe services programs and what kind of help they want. What was really striking about this was the large percentage of people who had used methamphetamine, both in the past 3 months and in the past week. So you can see in this that 49% of the people that we surveyed had used methamphetamine 5 to 7 days in the past week, which is a pretty high frequency. And that 20% had used methamphetamine and heroin together 5 to 7 days in the past week. So really high prevalence of methamphetamine use. Just something that is different than previous years and worthy of attention. We also conducted qualitative interviews in 2018, myself and a grad student, Connor Henry, to find out sort of generally what things might be helpful for people at syringe services programs. It wasn't specifically about methamphetamine. We did ask people their motivations for using different drugs. And some themes that were emerged for why people were using methamphetamine was people were using to function. They were using to cope with heroin withdrawal. And it was very available. So one quote that really encapsulates all of that from those 2018 interviews is, well, right now meth is like really cheap and it's just everywhere. And if people get a little too high on heroin, they have to freaking try and wake themselves up a little bit so they can get done what they need to get done. So I think that encapsulates a lot of those different motivations. So these particular interviews that we did, we really wanted to follow up on and unpack a question we asked in the 2017 and 2019 surveys, which is how interested are you in reducing or stopping your stimulant use? With the response options of very, somewhat, not sure, or not interested. So in some ways, that was a little bit of a compound question, and we wanted to understand whether people wanted to reduce or they wanted to stop, and what went along with that very, somewhat, not sure, or not interested, to try and get more information about really what people meant by that. What was the intent, and also what kind of things people would find helpful based on their response to that question. So that's really the why we're doing it. We wanted to learn more about people who use methamphetamine and what would be helpful to them. So the goals was really to understand people's level of interest in reducing or stopping use, and to learn more about what services would help people achieve their substance use goals and improve health and quality of life. So the methods, we had a little bit of a challenge to figure out how we were going to do this during a time when we couldn't see people face to face. And we're really fortunate to have great partners in Blue Mountain Heart to Heart and Spokane Regional Health District who really made it possible. And we got a little creative. So we were able to do 27 semi-structured interviews with people at Washington syringe services programs. The interviews were 15 to 30 minutes, and participants received a $25 grocery gift card. Included anyone who was over 18 who'd used methamphetamine in the past week, and they were recruited by syringe services program staff. So basically what we did was we worked with the syringe services programs, advertised there. Sierra packed up basically like a box of materials for them, gift cards, you know, the informed consent, all the different materials they would need, ship those to the syringe services programs. The programs recruited people. Sarah and I, when we were doing the interviews, had like an open Zoom room that people could just drop into. So I think Sarah and I were both pretty happy with how that went. We did a large number of interviews in a pretty short time and didn't have to travel, which was, although I love doing interviews in person, in terms of being able to do a large number of interviews in a place I don't live, it was really great to be able to just open that Zoom room and keep recruiting until we'd reached a good number of people. Sarah, is there anything you want to share about what that experience was like?
I don't think so. I think you covered it well. Yeah, I think we both were just pleasantly surprised how smoothly everything went. So it's nice to know that Zoom is a good option for interviews like this.
So we recorded the interviews and then transcribed them using HIPAA compliant transcription, analyzed them using deduce with a combination of inductive and deductive analysis. Deduce was also great because it was an online platform where we were able to share that and really create codes that we felt like were meaningful. So who did we end up talking to? The interviews were spread across 3 sites, 19 in Spokane, 5 in Clarkston, and 3 in Kennewick. And the demographics roughly mirror those of the larger 2019 Syringe Services Program report. So the large majority of people were under 40, with about a third being 30 to 39 and a quarter 18 to 29. About 2/3 were male. About 3/4 of people were white, but with a pretty significant American Indian and multiracial groups. And then we didn't ask about people's housing status, but the large percentage of people were unhoused, which was something that they disclosed during the interviews. We also asked them about the frequency and length of their substance use as a way to sort of understand who we were talking to. The large majority of people had been using for more than 11 years. Almost everyone was a daily methamphetamine user. People were, over half of people were also using heroin. And most people were injecting or smoking, with the 5 people who were smoking only, which I think is pretty interesting. So that's who we talked to. I'm going to hand it over to Sierra to start talking about the overall themes and what we learned from everyone.
All right, so I'm just going to go over some of our key findings from these interviews, as well as several quotes directly from people that we talked to, which is my favorite part. But here's some of the overarching themes that came up over and over again during these interviews. First, most people that we talked to saw both benefit and harm from their methamphetamine use. Many people lacked stable housing, employment, or other basic needs like transportation, childcare, or healthcare. Self-reported level of interest wasn't always static. So there was a lot of ambivalence that people felt about their use. And then regardless of people's level of interest in reducing or stopping their use, people still wanted a really wide range of different social and healthcare services beyond just traditional substance use disorder treatment to help them reduce or stop their use. And then speaking personally, I think one of the most rewarding parts of doing these interviews for myself is that people were just really eager to share their experiences and just speak really candidly about what does and doesn't help them. And so I think it just goes to show that taking the time to speak with people one-on-one and just really understanding their unique circumstances goes a long way. Go to the next slide. So we didn't explicitly ask each person what their reasons for using meth were, unless they told us that they were not interested in reducing or stopping their use. But most people still shared with us several reasons for using, and a lot of people's reasons for use were related to benefit and withdrawal. So most people described how methamphetamine has played a beneficial or helpful role in their life, whether it's to help them function in a job, to avoid emotional pain or other negative feelings, and just to cope with really difficult life circumstances like homelessness. So for example, one person said, the job that I work at is really high energy. I don't really feel the effects of it. I use it as a tool to help with my energy level. And another person said, it helps with the pain of missing your kids. And I know it sounds harsh, but it numbs the pain. The other reason for use that came up a lot during these interviews was related to withdrawal. For example, a lot of people said that they wanted to quit, but they felt like they had to continue using in order to avoid the discomfort that comes from withdrawal. There were also a lot of people who shared that they couldn't necessarily afford to take the time off of work in order to kind of get through that period of withdrawal. And this quote below is actually probably my favorite from the interviews that we did. This person said, people take the simple things for granted, even just waking up and having a cup of coffee. I wish I could do that. Instead, I wake up and I have to get high or else I'm sick. We also asked each person a few questions just to better understand if they were interested in changing their methamphetamine use. So we asked about people's level of interest in reducing or stopping, if they were more interested in reducing or if they're more interested in stopping altogether, and then also what people's estimated time frame was for making that change. So we asked each person, how interested are you in reducing or stopping your methamphetamine use? And like Allison said, we gave the options of very interested, somewhat interested, not interested, or not sure. And as you can see from this graph, most people, about 85% of people, were either somewhat interested or very interested in reducing or stopping. And there were a few people who said they were not interested in reducing or stopping. And I believe just one person who said that they weren't sure if they wanted to. And we did want to note that even though people had very clear responses to this question, people's level of interest actually changed throughout the interview, which suggests that change and readiness to change are two separate things. And we also asked people to specify if they were interested in reducing or if they were interested in stopping altogether, which this graph also shows. A majority of people said that they wanted to quit, and quite a few people shared that they wanted to reduce their use. And again, there was a handful of people who said that they weren't interested in either, and one person who wasn't sure. And level of interest didn't always correlate to stopping or reducing. For example, being very interested didn't correspond to wanting to stop, and being somewhat interested didn't correlate to wanting to reduce. If people said that they were interested in reducing or stopping their use, we asked them, what is the time frame in which you see yourself stopping your use or reducing your use? And there are very few people who said that they were ready to quit or reduce immediately. Most people said that they would be ready within the next few months to about a year. There were also some people who weren't able to answer this question because they weren't sure how long it would take them to reduce or stop, which is a very reasonable answer. And we also wanted to note that there were several people that we talked to who said that they were actually already trying to taper down their use. In the interest of time, we're not going to go super in depth on this slide, but we did ask each person how they stay healthy while they're using meth or while they're trying to cut down. And most people talked about how they are very aware of the potential health consequences of using, but that they have several different strategies for staying healthy and reducing harms. So those strategies were things like balanced nutrition, just remembering to eat, eating healthy food. A lot of people talked about avoiding sugar. A lot of people share that they exercise and they're very active, walking every day, riding their bike. One person talked about how he really likes to take his dog to the dog park. Hydration and drinking water was another big one, just remembering to drink water throughout the day. And then also safe injection practices and not sharing or reusing needles. We also asked people why they wanted to reduce or stop their use. And just as a reminder, most of the people we talked to said that they were interested in cutting back or quitting. But even some of the people who said that they weren't necessarily interested still talked about some reasons for maybe wanting to cut back or quit in the future. So the most common motivator by far for cutting back or quitting was definitely family and relationships. Almost everyone we talked to described wanting to cut back or quit to maintain their relationships with their family members and especially their children. Many people shared that they currently don't have their kids, and so they want to stop their use in order to get their kids back. Some people talk about being scared of losing their kids in the future if they didn't reduce or stop. But also there were some people who identified the loss of their kids as a motivator to continue using. So this was definitely a really complex topic for many people. This participant shared that I don't have my son right now, and I want my son. I want to be a better father and be a role model. I can't be a role model if I'm using meth. And then desire for a normal life was another really common motivator that came up in these interviews, especially among people who are currently experiencing homelessness or maybe facing some other instabilities in their life. A lot of people described wanting to change their use really so they could enjoy a lot of the simple things in life that many of us probably take for granted, like having a job and our own place to live. For example, this person said, I'm trying to go back to a normal life, I guess. I've been doing the homeless drug addict for the last 12 years. It's getting old. A job and just supporting and having your own place. your own apartment and you get a job. It's mainly to be normal. Another common reason for wanting to reduce or quit was mental health. So a lot of people shared how meth makes them feel anxious, depressed, or paranoid, especially if they're dealing with a co-occurring mental health condition. This person said, it makes me go goofy, like thinking weird things, paranoia, seeing things in the nighttime, things that probably aren't there, but my mind fills in the blanks. And then similarly, a lot of people said that they wanted to reduce or quit because they wanted to maintain their physical health, especially as they were getting older. A lot of people talked about how they could just feel the physical wear and tear that meth has had on their bodies, whether it's through infections, dental problems, or just feeling worn down in general. Like this person said, I'm not getting any younger. The older that I get, I could just feel that I'm wearing down. And I'm pretty sure that methamphetamine speeds up that process. Okay, so now we're going to talk about all the different things that people said has been helpful in the past or would be helpful for them in the future when it comes to changing their use. For example, we asked people, what would help you reduce or stop your use? And are there any services that have been helpful? So as you can see from all of these different bubbles, people identified a really wide range of different resources that have helped or would help. It wasn't just one thing. Some of these are specific services and some of these things are less tangible. The most common was definitely relationships. Again, almost everyone we talked to said that meaningful social connections and relationships with their friends, family members, other people who have gone through similar experiences, and even their pets play a really key role in helping them to reduce or change their use and helping to keep them accountable while they're trying to change their use, which makes a lot of sense when we remember that most people's primary motivator for wanting to stop using was family and relationships. So this person said it would just be a matter of having the right support of peers, friends. When I made it 5 months, this last 2 months, it was my mom and my dad and my sister. So it's family, I guess. It's a matter of being around people instead of alone because I spent a lot of time alone on the streets. So yeah, being around people. And then people also brought up a really wide range of different substance use services that have been helpful. So things like support groups like AA or NA, case managers, and people who could help connect them to services, syringe services programs, and different forms of substance use treatment like inpatient, outpatient, and culturally relevant treatment. Like this person who said that he participates in a Native American-based sobriety group. He said, I just really enjoy it because of the community, and it just really creates a whole new family of sober people. And then a lot of people shared a number of different personal or individual factors that have helped them. And there were actually a few people who said that nothing else has helped them or would help them other than themselves. So things like internal drive and motivation, religion or spirituality, staying positive, setting realistic goals, and being held accountable by other people. This person said, I want to say internal drive. There's just been times I've wanted it more than other times, and when I want something, I tend to go get it. And then housing was another huge factor that came up for a lot of people, which again, a lot of the people we talked to were currently experiencing homelessness or maybe living in some other unstable housing situations. But a lot of people described how having housing of their own would help them gain some much needed stability, which could in turn help them to reduce or stop their use. For example, this person said, an apartment would be the easiest one. I have a culinary degree and I've been a chef for many years, but it's kind of hard to get into a restaurant job and say, hey, I'm a chef, but I'm homeless. I can't shower. And then many people talked about how engaging in purposeful activities like hobbies or learning new skills is super helpful. For a lot of people, they shared how staying busy with activities helps them to avoid boredom, which can often be a trigger for wanting to use for some people. This person said, I've always thought finding new hobbies, it could be a new skill or a new passion, probably helps a lot in getting rid of addiction. And then similarly, many people talked about employment and how having a job would be a really key stepping stone when it comes to accessing other basic needs like housing, food, daycare. This person in particular talked about how he's really proud of his work and how he wouldn't show up high to work. So a job would be really helpful in cutting back. And then lastly, a smaller number of people also brought up medications as helpful tools when it comes to cutting back or quitting. So a lot of the medications that people discussed were either related to mental health, like medications for anxiety or ADHD, or they were medications for opioid use disorder specifically. However, people still thought that these medications would be helpful in reducing their meth use as well. For example, this person said, I was on methadone for a while. It was so helpful. If I was still on methadone, I would still be clean today. And then moving on to barriers and what doesn't help, we asked everyone, what has prevented you from getting the help that you want? And just like the responses to what does help, people face really unique and complex barriers when it comes to cutting back or quitting meth. Everyone we spoke to was just very self-aware when it came to recognizing the different barriers that are in their way and preventing them from accessing the different resources that they want or maybe are interested in. And we divided these barriers into these 3 different levels: individual, community, and service level barriers. They do have some overlap, but they roughly fall into these 3 categories. At the individual level, barriers tended to fall into these 2 different buckets: a lack of basic needs and then personal issues. So a lot of people talked about how an overall lack of basic needs like food, transportation, childcare, and housing just makes it incredibly difficult to focus on cutting back or quitting because constantly working to meet these basic needs often takes priority, which is very reasonable. And this is a pretty long quote, but it's also one of my favorites. This person talked about how I finally have a home now, so that makes a huge difference. I think that was kind of key for me, was just having a home and transportation, the essentials to be able to function in society. I just needed those certain connections to society. And then most people that we talked to also brought up several individual or personal issues that have served as barriers. So things like a fear of failure, feeling like you won't succeed if you even try, lacking motivation or internal drive, or just not feeling ready to quit in general. This person said, it's nothing anybody can do for me. There's no treatment, no person, nobody that can help you. You have to do it for yourself. And if you're not willing to do that, then probably you're not going to stop. That's just the reality of it. Then moving on to community level barriers, these tended to fall into these 2 buckets: availability of meth and then judgment and stigma. So a lot of people talked about availability of meth as being a major barrier when it comes to cutting back or quitting. Many people said that they want to quit, but they just feel like they won't be able to because most of their friends or just people in their social circle are still using. A lot of people talked about how widespread and easily accessible it is in their communities. One person shared that as someone experiencing homelessness, it's often easier to get meth than it is to get food. And then this person also talked about how dealers tend to hang out in the homeless spots. And this was something that we heard in the 2018 interviews as well. And then, unfortunately, but not very surprising, another major community barrier that almost everyone discussed, whether they brought it up directly or indirectly, was judgment and stigma. A lot of people had experienced feeling shamed or judged by providers or family or friends, and it made them stop accessing certain services. It made them not want to try services again in the future. And judgment and stigma happens in many different settings. This quote is about treatment specifically, but people talked about experiencing it in shelters, from family members, pretty much in every aspect of their life. So it's a barrier to accessing all sorts of help and care. For example, this person said, I wish there was more outpatient that are more accepting. I just feel like people are really judgmental, and a lot of the resources that we do have, I feel really judged and belittled when I'm there, and I don't like it at all. That just makes me irritated, and it just makes me want to go use even more because it's stupid. And then looking at service level barriers, most of these barriers fall into these 4 different categories. In the interest of time, we're just going to focus on availability and accessibility of services, but people also shared how they weren't happy with the quality of services that were available to them. For example, some people felt that treatment programs underestimated them or they just weren't a great fit. There were also a few people who shared how it's been difficult to receive diagnoses, especially mental health issues like anxiety or ADHD due to their meth use. So looking at availability of services, a lot of people said that there just aren't very many treatment options available to them in their community. There was one person who talked about there was a few options local to him, but the wait list to start services are often so long that it's prevented him from actually taking advantage of those services. This person said there's no treatment facilities for recovery or anything. So if you want to quit, you have to go out of town and go through detox, and most drug addicts don't have any means of getting places. And then similarly, the accessibility of services was another common barrier. A lot of people talked about how even if there are services that are available, accessing them is difficult if you don't have the transportation to get there, if you can't afford to take time off of work, if you can't afford childcare. Like this person who said, trying to get back into methadone again, and it's so freaking hard to get into. It's just hard to get into because I have grandkids. You have to be up by a certain time. You have to get a babysitter. It's just a pain in the butt. And then at the end of each interview, we read off this list of different programs and services, and we asked each person if it's something that they would be interested in. So the services towards the top of this list are things that people were most interested in, things like housing, contingency management, and someone to help navigate services. And then the items at the bottom of this list received less interest. They were things like inpatient or residential substance use disorder treatment, outpatient treatment, and help with a specific health issue. For outpatient treatment specifically, we received a lot of mixed responses. There was a lot of ambivalence related to this service. A lot of people said it would just depend on the specific program because a lot of people had mixed experiences. And then for contingency management, we got a lot of really positive and pretty excited responses. Like people said it sounded cool or sweet. And we described it to participants as a program that gives people money or other incentives for cutting back on their meth use. And you may have noticed from the previous slide that most of the services people were interested in weren't directly related to traditional substance use treatment, except for contingency management, which we thought was interesting. After we read off our list of programs and services, we also asked people if there were any other things that they think would be helpful that maybe we missed. And people came up with a really wide range of services. So some people brought up some basic needs like transportation, dental care, and childcare. And then other people also talked about some more innovative ideas. Like one person had the idea for a hotline that people could call for extra advice and support related to meth specifically. Some other people talked about how they wished there was a space where people could just hang out with other people who are also trying to cut back or reduce their use and just do other activities or hobbies together. So to kind of summarize everything that we have touched on so far, we feel like these 3 themes, family and relationships, housing and stability, stigma and acceptance, were really interwoven throughout all of the interviews that we did, and they really showed up in every topic area. So when we asked people about their reasons for use, their reasons for wanting to cut back or quit, what helps them, what doesn't help them, these 3 themes almost always showed up.
Thanks so much, Sierra, for diving into those themes and explaining them so well. There's a little bit more information on each of those on the Prezi if you want to check it out on the report. I have a question here in the Q&A. I'm going to hold off on answering that till the end. I think it's a really good one. It's about withdrawal. So I'm about to get into the Q&A. If you start to think of them, start to enter them into the chat and into the Q&A. So I do want to identify some of the limitations, which is that we interviewed people at a syringe service program, and they may not be representative of all people who use meth. It's really a specific subset of people. Definitely, we can't draw conclusions about everyone who uses meth from these 27 people that we talked to. The large majority were unhoused. Most were white and had been using meth for a decade or more. So once again, we can't necessarily extrapolate to people who are housed and have stability about what services they would want, or about non-white groups of people who use methamphetamine, or newer users. It can be a little harder for us to guess what might be useful for them. But I do think one thing that does come out of this is that if you ask people about what they want and what they might find helpful, they're likely to tell you and be really self-aware and be able to really reflect on that. So I think that can come clearly across regardless of some of these other limitations. So I do think there's a good need for further research to look at preferences among other communities. However, I think we can make some recommendations. And the first one is, I think, really important. It's to meaningfully involve people who use methamphetamine in planning and implementation of services. People who use drugs have clear preferences and useful insights and ideas. So this is really about focusing on making sure we include the people who we're trying to help and support. And people who use meth are people primarily, and they have great ideas and a lot of insights into what would work for them. Yeah, I will post the link with the full report in the chat in just a second. So we want to include resources to help meet people's basic needs, such as food, housing, healthcare, and employment, and co-locate those services where possible. A huge number of people we spoke with really had a lot of challenges with meeting their basic needs. And for this group of people, their methamphetamine use was really intertwined with that in ways that would make it hard for them to address that use without also addressing some of these other things. The other piece of it is that people who use methamphetamine deserve housing, deserve healthcare, deserve to have their basic needs, even if they don't want to reduce or stop their use. So that if we focus on providing those services, we can improve people's health, and it's not contingent upon their use or non-use. One thing that came up that I think is really important is we want to allow people time for change and to support incremental behavior change. Most of the people we spoke with were already doing things to stay healthy or cut back on their use, if that was their goal. They were already doing a lot of things to try and improve their health and quality of life. And so we want to do whatever we can to support the things people are already doing and do what we can to enhance that. Also allowing that people aren't going to change their behavior overnight if that's their goal. So we want to make sure that people have time to change, that they're supported for the changes that they do make, and that it's not an expectation that it all happen at once. Another thing that came up a lot was to provide flexible walk-in access. People's lives were complex in different ways. For people who did have some stability, often they had responsibilities that made it challenging for them to show up for appointments at specific times. For people who were unhoused, that posed its own set of issues with making and keeping appointments. So provide flexible walk-in access is really important. We also really want to say we want to emphasize acceptance, self-efficacy, and meaningful personal connections. Over and over and over in these interviews, relationships came up, the need for personal connection, and how much harm it caused for people that experience judgment and stigma from their friends, family, service providers, general community. So there's just a lot of good that can be done by having non-judgmental services, having good support for people who are using methamphetamine. Some people talked about how peers could be helpful. And I think people just wanted someone to connect with, someone to listen to, someone who accepted them. Another really important recommendation is to train staff on harm reduction and effective engagement strategies for methamphetamine. People who are using meth, most of the people we talked to weren't ready to stop that day, if at all. So we think harm reduction is really important to help people stay healthy, help people really thrive, whether they use or don't use. And also talking about how to engage people who use methamphetamine, which may look different than people who use opioids. However, another sort of key point we touched upon in the themes is that many people's methamphetamine use was intertwined with their opioid use. And sometimes addressing one would mean addressing both, or it would be good to address them simultaneously. So we really want to make sure that people know about harm reduction, have good strategies to engage people who use methamphetamine, because people who use methamphetamine are interested in their health. They are interested in their quality of life. They, are great. They're great to talk to. So I know that Sierra kept saying, wow, talking to these people was fun. I don't know if I mean fun, but like they're really interesting to talk to. And I had that same experience. It was such a wonderful experience to talk to the group of people that we talked to. They really were self-aware, self-reflective, and just really engaging to speak with. So I have a whole list of resources here before we dive into questions. We have resources on learnabouttreatment.org about stimulant use disorder, including some info briefs about helping people use opioids and stimulants and why people are using opioids and stimulants. We have a methamphetamine overdose and overamping brochure. I have a link to a journal article by Dr. Vanessa McMahon, who did sort of a deep dive into some of the 2019 syringe services program data. And I have a link to methamphetamine trends in Washington State from the WA data page. So I see we already have 7 questions, and I'm going, and here's our contact information in case there's something we don't touch on. I'm going to start the questions by saying I have a public health degree and I am not a treatment professional. So I see one question in the chat that I cannot answer already, which is thoughts on contingency management specifically tied to MAMP use. So these are the kind of questions I cannot necessarily answer, but that maybe we have some of my colleagues who work on SOAR who are on here who can take notes and maybe provide future trainings. I'm not a contingency management expert. I sort of anticipated we'd have had a lot of questions about that. I cannot answer them, but I can try and connect you with someone who can in the future. So I'm going to look at the other questions, which maybe I'll have more success with. So the first one I'm going to leave up to Sierra, which is when people spoke about withdrawal being one of the greatest barriers, was there a specification of which withdrawal symptoms were most challenging? I think of sick being more associated with heroin use, but meth more about feeling unwell, emotionally paranoid, sleeping issues, etc.
Yeah, I think what you said was very accurate. Most people talked about more of those like mental health issues and just feeling like very, very, very down when they are withdrawing from meth. Remember, there was one person we talked to who said that she just feels so down that she can't get up for a few days, and she has kids, and so she just felt like she couldn't stop. So yeah, I think what you said was very accurate to what we heard in these interviews.
I see from my buddy Sean Hammerly, did you ask participants if they kept naloxone available while using methamphetamine? And Sean, I am sorry that we did not ask that question, but I will ask a naloxone question in the future, and thank you for asking that. People didn't really talk, interestingly, people didn't really talk about opioid overdose very much, or really acute consequences of methamphetamine very often. And it may have been how we structured the questions that it didn't come up so much. But yeah, I mean, a lot of what people talked about was just like the daily grind kind of stuff. So sorry I didn't ask about naloxone, Sean. See, was there a significant difference in resources desired from newer users? I don't know that we looked at that, did we, Sierra? We can.
I don't think so. I do remember a couple of the people we talked to who had been using not very often, and they were more interested in like some of the support groups. But again, those are only a couple of people, so I'm not sure how generalizable that is. That's a great question.
Yeah, I think we could look at that a little bit. One thing that I think is really important is that even the people who were not interested in reducing or stopping their use were interested in at least one service. So I don't think we have to center services based on people's desire to quit or cut back. I think we should center services on what people say is helpful based on these interviews. So I have a question. Did anyone mention specific professions/services that were helpful or unhelpful? Occupational therapy, psychiatry, psychology, etc. Or explain more about why inpatient was the least helpful. Sierra, do you want to try that one or do you want me to?
I'll let you go first.
Yeah, people talked about some of the reasons inpatient was unhelpful, as it was hard to leave their family or friends in order to go do inpatient. It was hard to be able to take that time. And then some people talked about, one person talked about how inpatient wasn't long enough. Like he did well in inpatient, but he left and just resumed using, that it wasn't long enough for him to really make that fixed behavior change. Other reasons were that people didn't really like the approach of inpatient. Other professions people thought were helpful. I mean, people had pretty good experience in different groups, like NA and AA. People found peer support to be helpful. So it was really a mix, and it was very dependent on the person and what their experience was. I know that many times people didn't like specific programs because they'd had a personally bad experience and felt stigmatized and judged. So I think the big takeaway is the most helpful experience was one where someone felt accepted and listened to. I see a question from my colleague, Jason Williams. You hinted that people found it difficult to get a diagnosis because of stigma around their meth use. To what extent did people discuss how useful an SUD diagnosis would be for them? Did some sort of endorse the disorder idea and see it as a way to get services, while some reject the idea of disorder? Interesting. Sierra, do you want to try?
So there were a few people who talked about not being able to get medications for their ADHD specifically. So that's kind of the example that comes to mind for me. A lot of people said that just doctors didn't take their other potential health problems seriously once they found out that they're struggling with a substance use disorder. But the ADHD thing came up a lot, and there were quite a few people who said that was actually one of their primary reasons for using meth, and that if they could get ADHD medications, that would probably reduce their use as well.
I think to answer a little bit more of Jason's question, people didn't really talk about whether or not they'd been diagnosed with stimulant use disorder, but most people were aware that their use was having negative impacts on their life, and many of them had previously been in some sort of treatment program. So I think they were, when Sarah was talking about diagnosis, I think it was more of the mental health diagnosis piece, where people were having people's methamphetamine use made it challenging for them to get a specific mental health diagnosis. And I think some people thought it would be helpful to get that diagnosis so that they could start to address those mental health issues that they felt were driving that use. Hope that sort of answered your question, Jason. I have a great question, which is, thank you for your great work in this informative presentation, which thank you for the compliment. I may have missed this. Have you taken the summary back to the participants? What did they think, and any feedback? So Sierra did a great job creating a one-page summary for syringe services program participants. It had a QR code with a link to the report. We distributed this back to the programs, but we haven't heard anything from them about what the feedback was, but I certainly would love to hear it. I'll reach back out. I think Sam Carroll, who helped us with this in Spokane, is on the call. So if there's anything she's heard, feel free to jump into the chat, Sam. see a question. Did anyone express interest in changing the way they use meth, switching to smoking versus injecting? Sarah, do you want to try?
Yeah, I think there were a few people who talked about wanting to switch to smoking if they couldn't hit their veins anymore, or just because they felt like it was a safer alternative. But there were also a few people who talked about doing the opposite, switching to injecting rather than smoking because they felt like they used more since smoking was usually more of a social thing. So they thought that they might actually use less if they were injecting because it was more of a private thing.
It's a great question though. And it's something we're actually looking at a little bit with the 2021 Syringe Services Program survey, which is done and now we'll have results at some point in the future. And I have a question that's very similar to Jason's about mental health diagnosis. Said, did they not have access to providers or that they were being misdiagnosed or only diagnosed with stimulant use disorder? From the people we talked to, it sounded like their stimulant use made it challenging for providers to diagnose them and that they also had difficulty accessing providers. So it was an access issue and challenges being diagnosed because of their stimulant use. And then I think we have questions in the chat too. I'm gonna, let's see. Thanks, Kayla, for posting that. I will be posting the PowerPoint to the page and I'll be emailing it out as a follow-up. So I see a question. Any information on use of alternative methods to curb addiction, such as the use of kratom? That did not come up in any of the interviews, as far as I remember. Sierra, did anyone mention kratom?
No, I don't think so.
Mostly when people talked about cutting back on their own, they mostly talked about tapering and having a really set strategy for tapering that included, for some of them, not going out. So one person talked about how they were tapering their use. They had a goal of a certain date for when they were going to stop using, and that part of their strategy for stopping was to not go out after 9 p.m. So it was more behavioral strategies rather than other substances, at least in the people we talked to. And I see Sam saying, yes, she'll distribute the handout. And thanks, Sam, for being on this. So are there any other questions that people had or things they think we should have looked at? Let's see. Great presentation. Do you have plans to conduct similar interviews seeking diversity in respondents? Currently, we don't have plans to conduct more interviews at this point, but I think it was definitely worth doing. I think the challenge is I know that Caleb and Susan and I have talked a lot about how challenging it is to reach people who only smoke methamphetamine because they're not likely to be at syringe services programs. And it's way easier to interview people who go to syringe services programs because we have people like Sam who can hand someone off to us. And in general, reaching people who only smoke drugs has been, it's been a real challenge for us. So I don't have plans. I think it's a great idea. I think it's something we will keep talking about. Any other questions or anything else people want to ask us about? Thanks, Lisa. Thank you for sharing all of this. Thank you for posting this to the listserv. I see. Thank you for such an informative presentation. Any other questions or anything? Oh, thanks, Peter. I'm glad you're on this. I see lots of thank yous. This presentation, the recording and the slides will be posted on ADAI. There's no CEUs. I'm really sorry. I can send you a certificate though if you want it. For people who want one, just let me know. So I am gonna stop recording at least. And yeah, all of this will be sent to you in a follow-up.